welcome everyone to a co-branded OTA and AOFAS webinar on post-traumatic reconstruction after Hindfoot trauma. Couldn't have asked for more appropriate faculty for this dual-branded webinar. Joining us tonight are Drs. Brian Weatherford and Jan Sakowski. Brian is at Illinois Bone and Joint and is dual fellowship trained in trauma, shock trauma, and foot and ankle at Grand Rapids. Jan is dual fellowship trained in trauma and foot and ankle at the Campbell Clinic. So the way it will break down is Brian will be talking about basic principles. Jan will then talk about tailless reconstruction, and then I'll follow up with reconstruction of the calcaneus. And without further ado, I'll hand it over to Brian Weatherford from Illinois Bone and Joint talking about basic principles. Brian?
Thanks a lot, Pat. I really appreciate it. So thanks for having me, everyone. So I'm Brian Weatherford. I'm from Illinois Bone and Joint. So like Pat had said, this is a topic kind of near and dear to my heart, post-traumatic reconstruction. So the goal of this talk is just to hopefully give you some basic principles to think about when you're managing these problems. There's no right or wrong answer for this. That's kind of what's fun and challenging about it. So as we go through the talk here, so you can see just some of the options available to you. So I have some disclosures, none of which are relevant to this topic. The way I think about this is you want to think about the problem at hand, so the deformity or whatever you're dealing with. You want to think about the patient and what they bring to the equation. And obviously, perhaps the most challenging, you want to think about yourself. And what you can accomplish and what you feel comfortable in doing. The fun thing about hindfoot reconstruction or any kind of reconstructive procedure after trauma is it's kind of a choose-your-own adventure. And especially with foot and ankle, your options are to do some kind of a reconstruction or deformity correction. You can do a fusion. You can get into arthroplasty. You can even ride the frame and just get really crazy with it. The patient expectations, though, are absolutely essential in this situation. So for all of these folks, a lot of them have been through bad trauma, perhaps multiple surgeries, dealt with infections, and they have to understand if they're going to go through this process with you that, you know, you're helping them to get better, but it's never going to be the same. And I think a lot of these folks who are coming to you with these really complex problems, they need to have a conversation with you about amputation. I think it needs to be brought up. Certainly not every single time. If someone's coming to you for a subtalar arthrodesis after a calcaneal fracture, I don't think that needs to be thrown out there. But for some of these issues, I think they could potentially be better with an amputation than they would be in salvaging their limb, and that's an important thing to discuss. So understanding the problem is, for me, basic preoperative planning. I think sometimes we get lost in all of the kind of fun, cool things we can do, and we forget to just sit down and make a nice list of what the issues are and how we're going to address them one after another. I think you have to understand what the patient is really looking to get out of the situation, and sometimes that's hard. I think you look at an x-ray, or certainly I do, and I think about all the fun things I could do and all the great ways I could reconstruct it and make it look great, and you have to understand what the patient is looking to accomplish. And again, understanding yourself and what you're capable of is absolutely essential when you're going to take on these issues. So the history for me is probably the most essential aspect of dealing with these issues. So for these folks, you want to understand, what happened with their injury, what their previous treatments are, what they've tried. I mean, if you have someone coming to you who has a simple, straightforward deformity and they haven't had bracing, orthotics, injections, something like that, I think you have to go down that pathway before you put them through some complex operation. You want to really dive into whether or not they've had prior infections, what their function was before this injury happened, and what their current limitations are. In other words, the limitations such that it merits them going through a very complex operation with a high risk profile to achieve just a marginal gain in their function. And so again, you can see this patient, the picture here, this guy really owned his AFO brace there. His daughter bedazzled it for him, and he loves it. This guy's got post-traumatic arthritis after a tibial pilon fracture, and he's loving his life with his brace. Okay, so in terms of the, we skipped a slide there. Let's go back here, history, labs. Oh, looks like our physical exam slide disappeared. So definitely want to emphasize physical exam, guys. Sorry, we're moving through this. So we did have an imaging slide on, or a slide on physical examination. So the things for me that I look for with physical exam, you want to look at the previous incisions. You absolutely want to have the patient standing and look at their hindfoot alignment when they're standing. I think it's very helpful in that situation to actually take pictures of it. so you can remember that for future reference. And I know we have that coming up in our talks as well. The other things with their physical examination, sensation is absolutely important. You want to figure out if they have intact sensation. Certainly if that person has neuropathy, that's going to change your algorithm for addressing their issues. In terms of imaging, I don't have any one right answer. What I can tell you is that weight-bearing imaging of the foot and ankle is absolutely essential to my practice. If your patient is able to bear weight, getting weight-bearing plain radiographs is the foundation of whatever you're going to do, and it helps you understand how you're going to basically attack that reconstruction. A lot of these patients, I think you can get standing alignment views on them, and it's very important to understand their deformity. The image you see here is a gentleman who presented with what looked like straightforward post-traumatic ankle arthritis, but you can see here the guy's got a significant valgus deformity and shortening of his limb. So if you're going to do anything to address his ankle arthritis, you have to address first his underlying deformity. I think the other things that have been helpful to my practice, if you have access to a weight-bearing CT scanner, I think it can be very helpful for preoperative planning. Beyond that, I think the case-by-case basis determines the other imaging studies you get, whether you're looking for signs of infection, whether you need to get an ultrasound examination, which I think is very helpful for looking for associated ligament or tendon issues, so on and so forth. So laboratory evaluation for these patients, again, you want to look for signs of infection. I think that's mandatory, even if they've never had a history of infection. You want to optimize their bone health. This isn't an acute trauma. You have an opportunity to make the patient have the best possible situation for healing. Same thing with nutrition, and I get vascular studies on a lot of these folks as well, too, to make sure they have adequate inflow to heal these major surgeries that they have. So I hope that was helpful for everyone. I'm actually going to jump into a case right now just to kind of give you an idea of some of the issues you may face when you deal with these things. And this guy's got a combination of both talus and calcaneal issues that kind of need to be addressed. And you can see how I took it on, and I don't think it's the right answer necessarily, but it's just an option. So this is a 34-year-old guy who had an isolated injury, was in a motorcycle collision, and presents with the images that you see here. And we have his CT scan here. And so what you can see is this gentleman, in fact, had a closed, extruded talus, basically down through his navicular, obviously a severe injury. So I had access to his images. I didn't get involved in his care until later, but he had an initial external fixator with pins across the subtalar and talonavicular joint. First of all, he did an incredible job just getting his talus back underneath the ankle and on top of the calcaneus after that injury. This guy was treated definitively with these wires and this external fixator. And you can see there's definitely some incongruity at the talonavicular joint there. His lateral column is short with crushing of the cuboid. And you can kind of see what happens. The talus just goes right back to its home. So they took his X-Fix off, and he comes back into the office, and his talus just trying to go right back where it started, down through the navicular and out the bottom of his foot. So he had another operation where they did what I would call a medial column fusion at the talonavicular joint and the navicular cuneiform joint there. If you're looking carefully there, you can see something's maybe looking a little funny here. And also you might have noticed that his second metatarsal base is sticking way up in the air too, so he's got an associated midfoot fracture dislocation. So 5 months after this, or about 1 year after his injury, they note that he's got a draining wound and his labs are elevated. So they take his plate out, he gets debridement, he gets antibiotics. Then he comes to see you because you're the guy that's going to help him. He's off of his antibiotics now, but his laboratory markers are still elevated. White count's normal, but ESR and CRP are elevated. Still in a lot of pain. Still can't walk. This is what we got now. So hope you guys are picking up on what's going on. So they didn't get all the hardware out, unfortunately. Still got that midfoot dislocation. Things are looking fragmented. Talus isn't looking too great. Definitely some deformity evident. Here's his weight-bearing CT scan. You can see that the ankle joint, subtalar joint, talonavicular joint, all of these things are looking pretty rough. And the talus doesn't look so much alive anymore. And there's his hindfoot deformity with his subfibular impingement. There's his draining wound. There's his hindfoot alignment. So we're going to get into this in a little bit, and I'm going to ask my colleagues here to take a look at that and see what they would do, and then we'll go through what I did. In summary, you want to make a list. You want to try to visualize your end result and develop a surgical tactic just like we learned in our AO basic courses. You want to understand the patient, really understand what are their goals, what do they do for a living, what do they like to do, can they understand what is required to go through this process, which for me is the hardest thing to know, and then can they tolerate what is required? and then understand yourself. What can you do? Can you do a fusion? Can you do reconstruction? Are you comfortable doing a circular frame or hexapod external fixator? Can you do arthroplasty? And then for these patients, it's usually a team effort. What resources do you have available to you? And what mentors can you lean on when you have really complex problems? Because that's really going to help you get through this. And sometimes maybe a referral is appropriate. Oops. Skip through that. That's for later. Okay. All right. So again, basic principles. Understand the problem, the patient, yourself. Choose your intervention, and please manage your patient expectations. And now I'll turn it over to Jan, who is going to take us, whoops, I just snuck in there. So Jan is going to take us through the talus here and tell us all about what we need to know about talus reconstruction.
Well, thanks, Brian, for the introduction. Great start. Good evening, everybody. I'd like to thank the OTA, AOFAS, Brian Weatherford, and Patrick Yoon for inviting me to be part of this webinar. So when I heard I was going to be talking about the talus, I got really excited. I think this is the best bone in the hindfoot, right? High rate of complication, high rate of AVN, malunion, non-union, post-traumatic arthritis. It just has so many things. It's like an orthopedic annuity a lot of times. So acknowledgments here. I'd like to thank the OTA talks as well as a lot of the other my mentors throughout the years. So this is the problem, right? We have a high-energy talus fracture, talar neck fracture. A lot of times they're associated with open injuries and so forth. And, you know we can fix them sometimes, maybe sometimes a little bit better. Sometimes they're harder to fix. But what we really want to prevent is the stage protocol. Now, you can see I'm really smiling here because it's leg day. This guy had a great sense of humor when he had an open talus fracture that unfortunately ended up infected and so forth. But he had a great sense of humor that many patients don't share their enthusiasm for leg day as him and I do. So once again, we start off with this, right? That's what's coming in the ER, and we're like, oh boy, when are we going to fix it? We can, that we're not. This is not an acute fracture talk where we could talk about timing and approaches and so forth. But we kind of want to prevent this, right? There's sclerosis, there's a loss of height, there's arthritis. We definitely have some AVN there. It's some dead bone, and dead bone is bad bone. And when you look at this, sometimes we're going to end up like that, right? It might be infected. We're resecting some of the dead bone that hasn't healed or is sclerotic. We wish we could always do this, right? We wish there was always a great replacement solution. Unfortunately, that's not always the case. We might have to be using some femoral head allograft or some type of bone graft of our choice. And even now with some of the new latest technologies, we can sometimes even have 3D printed implants, and I'll go over this a little bit. I think this is actually going to help at least give us another option. So where do we go, right? We got all these options, right? We got fusion, we got resection, we got amputation. Well, first of all, a little background. Second most common tarsal bone injury, and that once again, it's my favorite bone in the hindfoot. Lots of dorsal and medial comminution. It's usually open. It's high energy, right? So lots of problems, right? And with that is going to be a lot of complications, right? Delayed union, malunion, non-union, especially in varus, AVN and osteonecrosis, post-traumatic arthritis. Because once again, my favorite bone in the hindfoot has several joints that it's a part of: the tibiotalar, subtalar, talar navicular. So what's our objective here? It's to save the foot, right? But at what cost when we're thinking about this? As Brian mentioned, there's a lot of to do with patient education and expectation, and the A word must be discussed, unfortunately. Yeah, it's the dreaded A word. We even learned it in medical school. The A word of anatomy, right? 60% covered by articular cartilage, and that's why it's my favorite bone in the hindfoot, right? 3 joints, right? I mean, that's better than the calcaneus and everything that Patrick's going to talk about. So it's your tibiotalar, subtalar, talar navicular, limited area for vascular supply. When I think limited blood supply, I think bad healing. I think a lot of complications. Just think about anywhere else in the body. So when we think about these bone defects in the talus, there's deformity, right? Brian talked about that. He went over the slide of getting the full-length X-ray. That's essential. Think about shortening, gait alteration. People don't like to walk short. They get hip pain, knee pain. They just don't like the cosmetic appearance of it. You also get adjacent joint disease like you do in the spine. We get it in the foot all the time, as you can see here in this X-ray of the talar navicular joint. You also get shoe wear difficulties. These are a lot of problems that these bone defects are resulting in. So the questions I have, now Brian had a list of questions, and they're great, and this kind of goes along with that. My first question is always, is there an infection? And that should almost be the first 3 or 4 questions, because you should always be suspicious about this. How much bone is salvageable? Remember, dead bone is usually bad bone. What is the demand expectation of the patient? We can make it better, but we can't restore normal, and it's really essential to take time with the patient and go over that, and even with yourself. You can't just make it perfect again. What is the deformity? And as one of my partners always says, and I think this is going to be the key, he says, order an H&P, right? You got to get a history and physical on these patients to really get to know them. So was it closed versus open? What approaches were used, right? We already know that it has bad blood supply, but what approaches were used? Was there a flap? Do they smoke? Do they drink? Health status, diabetes, obesity, right? That's with any type of orthopedic injury, but it's something always to consider. So once again, soft tissues. What are the current soft tissues? What was used before? What incisions can you use now? Something to always think about when seeing these patients and evaluating them. Is there an infection, right? I think when there's an infection, at least I know stage 1. Stage 1 is everybody out of the pool. Get the hardware out, resect anything that's dead or infected, and put an antibiotic spacer, and then reassess. And then you can talk about an acute versus stage reconstruction later on, and it gives you an idea of what you're dealing with. So I always try to do that as the first stage, and then unfortunately sometimes that does lead to amputation. But as discussed, that's not necessarily a failure, but can actually help the patient progress and move on in certain instances. So the next steps, labs, they're not reliable, right? If you can get an ESR CRP, they can be totally normal. There's no infection, there is an infection, excuse me. Imaging, CT scan, I love to get weight-bearing CTs. They're not always readily available, but they provide a lot of information, kind of like standing X-ray films. MRI can be helpful as well, especially when looking for AVN, but a lot of times if there's already hardware in it, you're going to need metal suppression, and it can be a little bit confusing. So non-unions, right? CTs are great at this, as you can see here in the image on the left, and the 2 cuts, a non-united talar neck fracture. But usually a non-union, unfortunately, I think it's hard to find a simple non-union in the talus. There's usually some associated deformity or AVN. Especially, we find it more typically, I think, malunions, right? There's a typical deformity is going to be varus, and as Brian mentioned, look at the patient's legs, have them stand, and try to take a photo in the chart of this so you can kind of continue to pre-op plan them later on. Options, once again, always think, do surgery on your shoes before you do surgery on your feet, right? Think about orthotics and braces, and then start thinking about what you can possibly do for surgery once you get to know the patient, including osteotomies, fusions, and so forth. And those are going to be really related to the problem that you find, and also the patient expectation about what they're looking forward to do in the future in terms of activity and function. AVN, right? Like I said, dead bone is usually bad bone. Talus fractures have a very high rate of AVN overall. You can usually diagnose this on X-ray just with plain radiographs. MRI can be helpful as well. As you can see here, there's a lot of sclerosis. There's flattening of the joint as well, increased density seen on the X-rays. This one's pretty obvious. So when we look at the reconstructive options, now we're getting to the meat finally, okay, with my favorite bone in the hindfoot. We can talk about bone grafting for non-unions, right? I think if you have a simple non-union, that is going to be a reasonable option. Soft tissue management. Think about your Achilles, and many of these patients have Achilles contractures. Maybe they were in an X-fix for a while as well. You can think about osteotomies, especially lateral calcaneal slide, get that heel out of varus. And then the fusions. So fusions are going to be our workhorse, whether it be the tibiotalar, subtalar, both of those, or even the talar navicular. And of course, replacement, right? That's becoming more in vogue. Unfortunately, even though they're in vogue and right now, that's not always an option, or I would say almost almost all the time when we're dealing with hindfoot reconstruction. That is not currently an option, unfortunately. So no matter how much we like to think a replacement will solve all problems right now. So I go back to the principle of do simple better. So the Cubs finally won the World Series again a couple years ago, right? And Madden was their manager, and his big slogan was do simple better. And I think this is key, right? Go back to the principles, as Brian mentioned, back to the your AO courses, and just think about, okay, first do no harm, and then do simple better. Keep it simple. So you have a patient here. This is one of the cases, comminuted talar neck fracture. He was treated an outside hospital and continue to have, problems, developed an infection. You can see there's a lot of comminution and bone loss here. It was an open injury. So one of the options could be, keeping it simple, is just a talectomy, right? Take it out. This is a valid treatment option, especially for high-risk patients. It can be a reasonable option for limb salvage. Obviously, they're going to have some gait problems, but they still have their foot, and they can ambulate. In this patient, though, unfortunately had an infection, needed an antibiotic cement spacer once again. So dead bone is bad bone, so you get it out. You put antibiotics there, just almost like a masculate technique. You treat them locally with antibiotics, high dose with antibiotic cement, and then with IV antibiotics as well. And then later on, they can go on to a fusion with a TTC nail. With a concurrent talectomy. Another option is always going to be the femoral head allograft. Okay, this is readily available. It's relatively cheap. You can cut it to whatever size you need and you want. You have different head sizes available. I prefer sometimes like a step cut. I think it provides some inherent stability here. And you can kind of, in a way, make it fit the patient that you're trying to fuse. Unfortunately, though, this looks great on initial X-rays many times. The patients can lead to a non-union, especially in diabetics and smokers. So one of the options for all the total hip enthusiasts out there is actually to do a femoral head allograft, but use a acetabular reamer. This can provide some inherent stability when done. I think in my hands it's a little more finicky. That's why I prefer flat cuts, but this is a very good technique when done for the right indications. My personal favorite is using the fibula. I think the fibula is like a vestigial organ that we have, okay? And we don't really need the fibula, especially when we're doing fusions. And that's just my bias. So I cut the fibula out many times, and we'll use it for local autograft. You can use it for structural autograft. You can also use a bone mill and be able to provide quite a bit of bone graft for that area and help you reduce the deformity. As you can see in the lower picture, though, the adjacent joint disease, right? We got a fusion. We got a nice fusion in the hindfoot, but the talar navicular joint is suffering. So there's always a cost to anything we do. What about trabecular metal spacers, right? We're going back to the total hip, total knee enthusiasts. We're taking some of their tools that they have in their toolbox. And this is, especially with 3D printed technology, this is becoming more popular and more readily available. Less subsidence, but much higher cost. And sometimes it's hard to image in terms of seeing if you actually have a solid fusion or not. So now we go back to the total talus, right? Now this is, I think, something that's going to be changing in the next few years. There's a lot of groups, such as out at Duke, that have really made some great progress in 3D printed technology and doing this for total talus, especially just with isolated AVN and some tailored defects. I think the jury's still out about the longevity of this in some cases, but I think with 3D printed technology, I think there's a lot of at least hope and hopefully not all hype, and I think some of the early data is promising. So it's a big alternative to talectomy and fusion right now. And so in summary, once again, do an HMP. That history and physical is going to be key. Rule out infection. Rule out infection. Know your limits and get to know the patient. Manage expectations, as Brian Weatherford talked about, especially your own. I always say do simple better, and most of all, you got to always treat the patient. Know what they're expecting and try to gauge what kind of function that they want to go back to. And now I'm going to give the mic over to Patrick for reconstruction of the calcaneus.
Great. Thanks very much, Jan. That was a very complete talk on talus reconstruction. I got to say, if you don't include the navicular and the cuboid as the hindfoot, there's only two bones in the hindfoot, the talus and the calcaneus. That means this coming bone is your least favorite bone in the hindfoot, right? So Pat Yoon from the Minneapolis VA, I do want to acknowledge the years I've spent at Hennepin County Medical Center here in Minneapolis and my former partners and residents from whom I've learned so much over the years. Thanks to Sarah and OTA as well as AFAS for putting this on. So my disclosures are as follows. Nothing should really conflict with the topic of this talk. And of course, I do not plan to discuss any off-label use. When we're evaluating calcaneal malunion, there are a couple of issues that you have to keep in mind. There are a lot of issues you have to keep in mind. So when you see an X-ray like this, these are some of the thoughts that come first to mind. Of course, when you have a destroyed subtalar joint like that, subtalar arthrosis is probably the one that comes first to our minds. But there's a lot of other stuff going on as well, too. You can see that the patient has lost calcaneal height. Because of that loss of talar declination, they've developed anterior ankle impingement. You can see that talar neck and head abutting up against the front of the tibia there. And what that does, as you all probably know, is that it limits ankle dorsiflexion. Your talus, quote unquote, thinks that it's already dorsiflexed, so your foot doesn't go any higher than that at all. You can see the two lines there overlapping. So the top line's the top of the calc, and the bottom line's the bottom of the talus. Obviously, those two lines should be reversed, right? So there's lateral impingement that can be talocalcaneal or calcaneofibular impingement, and of course the heel shortening, both up, down, and also front, back. So those are kind of the most obvious things that come to mind when you see this X-ray. But remember, there's a patient around that, and you got to remember the soft tissue. So very commonly, you'll have perineal tendon issues that can include just direct impingement or pinching between the calc and the fibula, tears. It's very common to get subluxation. I think John Kwan at Harvard shows it happens about 25–30% of the time with calc fractures, and you may not see it, but it sees you. Of course, the skin envelope can be very thin and tenuous. If you have open calc fractures, you have these big medial wounds, and there are residuals to work with. And you can also see frequently the FHL involved in either tethered and caught in scar tissue or hardware even in some cases. But remember, there's the whole other half of the foot as well too. And so the back half of the foot can be doing one thing and the front half can be doing something else. So look at your forefoot alignment. Is the foot plantigrade, or are they walking on the outside part of their foot and developing lateral foot overload? So remember, there's not just the bones in the hind foot, but the skin around that and the bones in the forefoot and midfoot as well too. Keep in mind that not all lateral foot pain is subtalar arthrosis. So if you've had a patient who's had a previous calc fracture and they have lateral hind foot pain, you know, I fully admit a lot of us might just kind of knee-jerk immediately think subtalar arthritis, but there's a lot of other stuff going on as well too. We talked about subtalar impingement. If their pain is not quite so lateral, it's more kind of anterolateral, think about anterior ankle impingement. Remember that when you do develop ankle arthritis afterwards, those spurs tend to develop more lateral first than medial, at least on the distal tibia. They can have lateral foot pain from the hind foot being in varus. If it's not so much in the sinus tarsi, but more a little bit posterior and distal to that, then think the perineal tendons. As mentioned before, always have the patient stand up and look at their heels from behind and check their heel alignment. This patient has a relatively neutral hind foot on the left and obviously a very varus hind foot on the right. And that does a few things, as you're probably all aware. This decreases your foot's ability to absorb shock. Putting the subtalar joint in an inverted position makes it a rigid force transmission type of device. It's very useful for push-off, but not very good for shock absorption. And as you can see from what I've tried to show in the cartoon here, is that your forefoot has a lot more ability to compensate for valgus than it does for varus. So your forefoot will invert a lot easier, or supinate a lot easier than it will evert or go into pronation. So if your hind foot's already in varus, it really can't accommodate that all that well. So people tend to walk on the outside part of their foot, and that's one of the many reasons why, quote, thou shalt not varus, end quote. So when many of us heal varus, we kind of knee-jerk to the Coleman block test. Keep in mind in this case here, I kind of did it in this case here more for demonstration and teaching purposes, but if someone's got bad hind foot trauma, This is not typically due to a drop first ray. It's a rigid deformity, first of all, so it won't correct with Coleman block, and of course it's not due to drop first ray, so this should be a negative Coleman block test. Very commonly, if people have bad calc fracture, they may have other injuries as well too, and you're kind of wondering, okay, is this more subtalar arthrosis or ankle arthrosis? And as you can kind of guess from the patient's previous L-shaped extensile Berners style scar there, they've had a previous calc fracture, so this is probably a little more obvious. But in this case, we did do a diagnostic class therapeutic injection. I consider a relatively easy injection to do. Kind of draw a line in your mind between the tip of the fibula and the anterior process of the calcaneus, and just direct a 25 gauge needle orthogonal to the skin at that midpoint, and you can kind of drop a injection into the sinus tarsi / subtalar joint relatively easily. Keep in mind, we always want to, as Jan mentioned, treat the shoe first before cutting on the foot, and so always try and maximize conservative treatment as well. And infections in these cases are very common. They've had multiple previous procedures in many cases, so rather than stir up a hornet's nest of infection and further problems, it's always consider the non-options first before you dive right in with the scalpel. So bracing, starting on the upper left, a cushioned silicone heel cup in the lower left for people with bad heel pain after calc fracture is very useful. An AFO, oral anti-inflammatory medications, both over-the-counter and custom orthoses can be used. Ask the orthopedist to make it with a cushioned heel and pressure relief. And of course, some cases for a brief period, a 3D medical walking boot. So what if they have lateral impingement alone without subtalar arthrosis? So remember, if someone has some of these other causes for hindfoot pain, you don't have to jump right into a subtalar fusion. So you can do a decompression, a lateral wall exoccectomy, check the perineals because those can be torn, injured, and or subluxated, and check their heel alignment to make sure you don't also have to do some sort of concomitant calcaneal osteotomy. So this would be the so-called type 1 from the Tampa classification. So with the lateral wall exoccectomy, just basically peeling off the soft tissues with a full thickness flap as possible, taking care to protect your perineal tendons. Obviously, this is more of an acute setting here with the exposure for a calcaneus fracture, but the principles would be very much the same as elevating that lateral flap. And as you can see on the right-hand CT coronal slice there, more or less, this is approximate, to take off everything to the left of that red line. So you can really decompress that lateral space there and then the subfibular region. Now, if they have heel varus and you're not planning on doing a subtalar fusion, you can correct that or at least address and help improve things with calcaneal osteotomy. If you are doing a subtalar fusion, then you can correct some of that at the orthodesis site, though I will say a lot of these cases are fairly rigid and it's hard to mobilize that subtalar joint enough to get all the correction just through the subtalar joint. So in these cases, whether doing a subtalar fusion or not, a calcaneal osteotomy to valgicize the hindfoot can be very useful. That can be either pure slide or translation, like moving it lateral by a centimeter, so essentially a reverse typical calcaneal slide that you do for a flat foot. Or you can do a Dwyer type with a lateral closing wedge and just do a pure angular correction as well too. There are several other types described as well, but those are two of the commoner ones that I'll use, kind of an angular wedge, lateral closing wedge, or a pure translation. So here's an example here of a patient who had a hindfoot varus, and it's a typical lateral incision. I make mine typically about 45 degrees oblique. Taking care to protect the perineal tendons and sural nerve, of course, making a lateral to medial cut. Oftentimes, the medial side will be a little bit splintered or not quite orthogonal to the bony surface of the medial side, so it can take a little bit of distraction of the osteotomy first before you're able to translate it over by a centimeter. And at the end, you can stabilize this. Typically, I'll do this with two larger screws in the 6.5 millimeter range from posterior to anterior across the osteotomy site. And at the end of that, your alignment should be hopefully corrected, as you can see here. In some cases, after a particularly overzealous varus correction with a acute calcaneus fracture, you'll actually end up in some cases with a heel and a little bit of valgus. Not super common, but it can happen. And although this is typically better tolerated than varus, it can still cause problems. And this patient happened to have a lot of tension-related problems on the lateral side. So in this case here, he benefited from a varus-producing osteotomy. So when choosing your approach for this, if someone has relative neutral alignment and they have subtalar arthrosis, in these cases you could do an in situ subtalar arthrodesis. So we'll talk a little bit about subtalar arthrodesis. So these patients oftentimes have previous scars. If it's been a long time ago, you may get by, as in the left picture here with the previous L-shaped incision, with making a whole new sinus tarsi approach. If they have that previous L-shaped incision and you're a little bit leery of doing this, you can certainly do it just by making the vertical limb of that incision, as you can see in the middle. Or if you need to, you can kind of gradually kind of make a little bit more and more of that L, sometimes less, sometimes more, to gain exposure you need to. As mentioned before, it can be difficult to correct this line through the subtalar joint alone. So you may have to do some quite aggressive releasing in some cases to get that correction, or do an additional additional calcaneal osteotomy in addition to your arthrodesis as well. Don't forget to meticulously prepare the joint. Oftentimes a laminar spreader or a Hinterman tight retractor with K-wires through it can be very useful. I personally like to use an osteotomy and shingle the joint, but you can do it in many different ways. And then typically, you may end up with a little bit of a gap here if you've appropriately debrided all your necrotic dead bone. I think the upper right example was actually a rare example of a calcaneal non-union, which is why it was more of a debridement. But be that as it may, you're going to have some sort of a gap. Oftentimes it has to be bone grafted. The question then comes, do you bone graft it in situ with Cancell's chips or other forms, or do you do a structural bone block? And so that's the question. Typically, the traditional answer for this has been patients with anterior impingement. That's the indication for a bone block. So here's the intact calcaneus. Here's one with lots of height and anterior impingement. So when that happens, they may benefit from a bone block arthrodesis to restore the height. And to alleviate the impingement, you can put a laminar spreader inside the subtalar joint, raise it up, and then put your bone block in there to restore that height and alleviate that anterior impingement. Okay. Here's an example here of a before and after the bone block arthrodesis. You can see the talar declination has been nicely restored. Now, a couple of words about screw placement. You can either go with a more traditional construct here with 2 screws from the tuberosity up into the talus. I like to have screw 1 go lateral first up into the dome and to kind of encourage it to go into more valgus, right? And then put the medial one after that one. The second one will go into the head-neck junction, and only because the talar head-neck is kind of more medial than the dome is. Alternatively, there's another configuration you can do as well too, where you put more of a spread in between your screws. So you typically do your first screw like you would normally, and then your second one, instead of putting it through the heel, put it into the lateral calcaneus, kind of in that anterior process body junction. It looks kind of funny on the AP ankle view, but you get more of a spread in the lateral view and theoretically a bit more rotational stability because you have more of a spread between them. But it really is dealer's choice. So when is a subtalar fusion not enough? So if someone's got profound deformity, as you can see in this example here, this may be more than you can get corrected just with a subtalar fusion alone. So here's where you start thinking about more of a double or triple arthrodesis, a talar and subtalar joints. So in this patient example here, she had a significant hindfoot varus deformity. There was a little more you can correct with just a subtalar fusion. And also, if they have a lot of forefoot deformity accompanying that, it's hard to get control of that with just a subtalar fusion. So in this case, we did a double arthrodesis, the TN and subtalar joints, correcting that hindfoot varus nicely, as you can see here in the post and pre. How about peroneal tendons? You can have tears, impingement, and subluxation. This is actually relatively common. You can see the so-called flex sign in the CT scan here. So the left-hand X-ray is a little higher up. The right-hand CT scan is a little bit further down. You can see the peroneal tendon soft tissue shadow outside the groove where it's supposed to be, with the yellow arrows and then the red arrows showing the little donor site for that fleck in the left-hand CT scan. Different techniques to do this. My preferred ones, one I learned from Lou Schoen in Baltimore. You drill a hole up in the distal fibula and tamp the smooth surface down with a tamp into that drill hole to create more of a deeper groove, and then put drill holes or anchors into the distal fibula posterior aspect to indicate the superior perineal retinaculum there. That can be done a couple different ways. If you have your big L-shaped incision doing your calcaneal reconstruction through a bigger incision, you can just elevate your flap more and do the perineal reconstruction through that, as you can see on the left. Or, as on the right, I don't have a clinical photo for the example on the right, you'd also certainly make a smaller incision as well, too. Just put an anchor into the distal fibula to anchor the retinaculum in that way. So in summary, calcaneal malunion can involve a wide range of issues. Don't assume that all lateral foot pain is subtalar arthrosis. You can have lateral wall impingement, perineal tendon issues, lateral foot pain from heel varus, and other issues as well, too. So you may need to address these issues instead of or in addition to your subtalar fusion. So thanks very much. Sorry for going over, and I'll hand it back over to Brian. Cases.
All right. So great talk, Pat. So we're going to go back to that case example. I know it may have seemed like a while ago, but we can refresh your memory real quickly. But I would also encourage you guys, if you have questions, please fire away. I mean, whether it's on this case or any of the talks or just any questions you have about your practice in general as it relates to these issues, that's what we're here for. So we'll get rolling through this case. And again, like I said, this is not, this is just the way that I approach this problem. This isn't one right answer. So back to our guy here. Okay, this is how he comes to your office. So he's a year post-injury. He's had now 2 surgeries. One was his initial surgery for his extruded talus, which is an external fixator with wires, basically wires across the talonavicular and subtalar joint, and then a subsequent attempted fusion that had an infection. So he actually has had 3 surgeries, but still has these issues going on. So again, here's his lateral x-ray. So the talonavicular joint, as you can see, is subluxated. The navicular does not look like it's very good at all. He's got broken implants. He's got arthritis of the ankle joint, subtalar, talonavicular, and, oh, by the way, we've got the second metatarsal base fracture dislocation as well. You can see our images here, again, with the deformity of the foot, too. And, again, these is why the weight-bearing images are so helpful. You can see the abduction and translation, lateral translation, and lateral column shortening that he has here. This is his weight-bearing CT scan. You can see the density of the talus indicating that it is not alive anymore. The navicular is largely not present. Bad ankle, and this just highlights that valgus deformity we're seeing on his clinical exam. Here's his medial wound. There's his hindfoot valgus deformity on the affected side. So you can see basically his heel is just kind of slid out from underneath him there. So now what do we do, right? I mean, so this guy's here. Obviously, so he has been in a boot for months. He's still got an infection, and he's in pain, and he wants you to help solve his problem. Anything else you guys want to think about at this point? You just want to go for the old-fashioned, kind of ostrich approach of throw some antibiotics and let's do a brace and come back and see me in 6 months. Any options for salvage? And obviously, I think in this situation, amputation is a very reasonable consideration. So this is how I break it down. Again, so I want to try to understand the problem, right? Well, problem 1, he's got an infection. There's no doubt. This isn't a mystery. He's got elevated inflammatory markers. He's got a draining wound. He's had a previous infection. He's got broken implants. Bone's not healed. So understand problem number 1 is infection. You have to get rid of the infection before you can even proceed to the next step. Step 2, or problem 2, is dead bone. And unfortunately, in this situation, it looks like it's not just the talus bone. It's probably his navicular, or certainly most of it. Problem 3, he's got broken implants. And then problem 4 is his deformity, right? And so what is his deformity? If we break it down, he's got hindfoot valgus. He's got an apex plantar deformity of the hindfoot through his talonavicular joint. He's got abduction of the foot. He's got shortening of his lateral column, and just to throw it on there, he's got a midfoot dislocation. But these are things you have to think about and think about what can I reasonably get to in this operation or operations, and what of these things is going to benefit him. So understand the patient, all right? Well, this guy, I mean, this is an oversimplified explanation of multiple clinic visits, but this guy wants to be able to walk without using a boot. He understands, and I've told him, he's going to need a brace for the rest of his life, even if we're able to save his leg. He has come 3 different times where I've told him he needs to have an amputation. He's gotten a second opinion, and he understands he likely will end up with an amputation even if we do this. And so in that situation, I feel comfortable proceeding. What does he do for a living? Of course, the guy's a manual laborer. He works in a factory, loads boxes, and so can he understand what's required of him when he goes through this? This is the hardest thing. I have no idea, right? I mean, I think so. I certainly had a lot of talks with him about it. I think he understands that he's going to need more than one operation. I think he understands the chance of complication is really, really high. I think he understands that he could very likely lose his leg. I've told him that. Does he understand it? I hope. This guy is young and healthy, so he can tolerate, in a sense, the operations that are required to salvage his leg. Again, will it get him to where he needs to be? That's the hard part. And then understand yourself, right? So what can I do? So internal fixation, I'm super comfortable with that. It is a trauma fellowship, right? I love internal fixation. Foot and ankle, we did a lot of fusions. I feel very comfortable with that. In this situation, and I'm certainly open to all options, external fixation, like a circular frame, is certainly an option, but challenging, at least for me. And I know there are people out there who probably could manage this beautifully with a frame. I'm just not one of them. Arthroplasty for me is not an option in this situation. You have to have a talus to have an arthroplasty, and this guy doesn't have one. He doesn't even have a navicular. Resources, I've got, in this situation, I'm lucky. I do have good local resources in terms of a team approach with plastics and vascular and therapy and all those other things. And then mentors, yes, and they all got an email about this. Every single one of them got a PowerPoint with these guys' images asking, what the heck would you do? And unfortunately, you get 10 different answers. You got to just pick your favorite. Okay, so let's get to it. So stage one, get rid of the infection. So if you look carefully, this guy's got a nice, cute little antibiotic spacer where his navicular used to be. I got all of those broken screws out. You could argue I could have been certainly more aggressive and taken a lot of the talus out with this, and that's certainly a critique. The guy got culture-specific antibiotics. His inflammatory markers normalized. And then we went in for stage two. So in this situation, stage two for me was managing the bone defect of the talus with a femoral head allograft. I am, again, I've looked for alternatives to this. I have concerns with the allograft for late collapse or subsidence of it, which I think certainly can happen as you get some creeping substitution of the graft. However, I don't know if we have a much better option to manage that dead space of the bone defect at this point. Just like Jan, I make flat cuts. I think the acetabular reamer is a very nice thing. I just think I've had some issues with it, and I think flat cuts work great. That's what we did. I was concerned about utilizing a rod in this situation. Honestly, can't even remember why now. That's actually a proximal humerus plate that's just flipped upside down to match the lateral calcaneus. Just like Jan talked about, I used his fibula for its purpose, which is bone graft, and morselized that. Took bone graft from his femur as well, from a reamer irrigator aspirator. And then this is where things got a little weird, right? So to manage the navicular bone defect, I just used basically a very small foot masculae technique and took that spacer out and grafted into that. Now, the challenging thing, and this is where I couldn't really work around the problem, was how I'm going to get bone graft to heal to femoral head allograft. And as you can see, it kind of did it, but this is where we end up anyway. There's his hindfoot alignment. I went for the metatarsal defect as well. I osteotomized through his calcanea cuboid joint, but didn't do a lateral column lengthening, I think because I just kind of ran out of steam. Here he is at 6 months. So you can see the arrow is pointing out there. He's got a broken screw right where his fusion mass is kind of coming in to his femoral head allograft. Now, I think if you guys want to look really carefully here, and you always want to be your own worst critic, I think he's in a little bit of Aquinas or apex plantar. Certainly, I think I've in some ways rotated his medial column up, so you can see how much of that cuboid in the fifth metatarsal you're seeing there, and that actually has become an issue for him. He's got some callousing there. From a fusion perspective, remarkably, this guy, and these are not just selected CT cuts, this actually healed the vast majority of this, even spot welded that allograft to autograft junction, which is, I think, just dumb luck. And here's his clinical alignment. Now, I don't know if these videos are going to play or not. I got a couple of videos of the guy here. I don't know if that's going to work. It looks like it's not. So anyway, long story short, this guy also got a great brace, which is working very well for him. Here's him at 2.5 years post-op. leg still attached. Actually is doing remarkably well. So anyway, thank you. And guys, please send in your questions about this case. I think that this brings up a lot of good points. There's talus, there's calcaneus, bone defect, infection. So open to any and all thoughts.
Let's say in between the first and second debridement, it looks like there's a bunch more talus that got debrided. Did you see a lot more interim dead bone at the second debridement?
Yes. Yeah. So when we went back for the second stage, I actually tourniquet down and I'm just burring away basically at the talus, looking for any signs of life. As you can kind of tell from his CT scan too, that talus was going, and I was really concerned. I mean, obviously the issue I have from a common sense perspective is that we're replacing dead bone with dead bone, right? I mean, you're taking out the talus that's dead and you're putting in a dead block of femoral head. Obviously, the femoral head hopefully is going to be more structural and hold up for longer. But yeah, I mean, basically, one of these cases, when I'm trying to figure out what's alive and dead, I use the old, just kind of burrow away at it and see if it looks alive, and just kept picking away at his talus and just figured out ultimately that there's none of it that really looked healthy.
Great.
Yeah, Brian.
Yeah, go ahead.
I was going to ask, what's your timing actually between your first and second stage? When you put the antibiotic suspend spacer, you treat them with IV antibiotics. You said it's culture specific. How long are they off antibiotics before you say, okay, now it's time to do stage 2 and go for the reconstruction?
Yeah, so I mean, I have them off 2 weeks, no antibiotics. I repeat their labs. Laboratory values are normal, and there's no clinical signs. I have them come back to the office, and they have no clinical signs of infection. Then we basically will have their second stage booked at that point. Now, I don't think there's any right or wrong answer to that, and maybe someone has a more elegant protocol, but that's what I do. So I have them at least 2 weeks before we even talk about surgery to make sure that their labs stay normal and their foot looks normal before we go in for the reconstruction.
Got it. Excellent. Do we have another case?
Yeah. So if you guys got time, you want to do one more?
Yeah, okay. Let's try to do one more.
Okay. All right. So so this is another deformity case here, and so you can again, I'm hopeful that we can get some nice critiques questions on this. This is a 27-year-old female who was involved in a high-speed motor vehicle collision. She presented to an outside hospital with multiple fractures. She had femur, patella, forearm, calcaneus, no major closed head, abdominal injuries, anything like that. So she was treated acutely with rotting of her femur and fixation of the patella and the forearm. She was told she had a calcaneus fracture. She was placed in a bulky splint and told to come back for follow-up for surgical treatment of her calcaneus. So she actually went to a rehab facility much closer to her home, which wasn't near where she got her initial care, and sought another opinion about her calcaneus fracture at that time and was advised not to have surgery. And so she went with that, and unfortunately she was still having issues, and she found her way to me at about 8 months after her initial injury. So here she is right here. So the lateral image, and this is a big, I think for me, a big teaching point, right? So the lateral image looks fairly benign here. If you look at the mortise view, hope you guys can all see what's going on here. There's something hiding behind her fibula. And then the axial view, you can see her fracture line there. And so, Pat, you guys want to give a guess, venture a guess as what's going on here?
Well, I guess that there's a bone fragment from presumably the calcaneus sitting up against the fibula. And hard to tell from that heel view. I'm assuming we have a CT scan to show here, but I have one of those uncommon calcaneal non-unions. Yeah,
so she had a really interesting injury, and this is a tough one. So I think we have some residents and fellows, and this is just one you can't miss. It's very subtle, and you'll get this call, say, oh, she's having heel pain, X-rays read as normal, and this is where you got to do the job of the radiologist, and you can't miss these things. So this is her CT scan. So she had what's called a calcaneal fracture dislocation. And certainly there's debate about calcaneal fractures, whether operative or non-operative treatment is appropriate. This is not included in any of those studies, right? So this is something that needs operative treatment. Any joint that has a fracture dislocation, maybe not any joint, but most joints that have a fracture dislocation, you want to at least get the joint reduced. So the majority of her subtalar joint and the entire calcaneal tuberosity is actually not underneath her talus or her leg. It's between, basically wedged between her tibia and her talus, her fibula and her talus. This is where she is. So she's 27, she's healthy, she works as a bartender, and it hurts. She can't wear shoes, hurts her to walk all the time. She's walking, actually, in this case, unlike most calcaneal malunions, she's actually valgus and not varus. Although her tuberosity is in varus, her whole heel is way out from underneath her. So what do we do, right? So she's got a pretty clean fracture line. She's 8 months out. I don't think leaving it alone. So do you go for the heroic option, salvage the joint, try to be, and I've read Stefan Rammelt, I know Sanders and Michael Clare have some publications. I know Dr. Benershka has published on it, on osteotomies for malunions and joint salvage. Is that, you guys think that's an option here?
Gosh, it's been 8 months. You got to think that subtalar joint is arthritic, but that CT scan did look fairly clean. I think it'd be a reasonable option to consider osteotomizing right through the initial fracture line and trying to mobilize that back down. But boy, that would be tough. I guess the safest answer would be to try and do a subtalar fusion, but can't forget about decompressing that talofibular recess in there. That's a shame. That is one that would have been a lot easier to fix initially.
Yeah. So,
yeah, I agree. I don't know if this joint's salvageable. I think I would jump to fusion.
So I hedged a little bit. Oh, go ahead, Pat. Sorry.
I was just going to say one thing you did mention, but I can't stress enough for the audience, and you all probably know this already anyway, but that fracture type where the calcaneus is dislocated laterally and sitting up between the talus and the fibula is a fracture type that is specifically excluded when we talk about operative versus non-operative having no overall difference. I mean, that warrants surgery.
Yeah, agreed. And obviously she would have been a lot better even if she got post-traumatic arthritis, I think, with getting that repaired early, but we are here now. So I told her, that I thought that it's very likely she would end up with a fusion. I told her I would attempt to salvage the joint. So what I did, this is actually, there's a couple descriptions of this. This is kind of a variation on the sinus tarsi approach. There's several publications. Dr. Rammelt has written about it. But this is an osteotomy through her primary fracture line, which is challenging. I mean, the deformity is challenging to manage. But I just thought that even if I fused her subtalar joint, I had to get her tuberosity and her heel basically back under her limb somehow, and this was the way that I could have done it. Now, there's, I think, several ways you could have done this. I think a Dwyer osteotomy with probably a lateral closing wedge but medial slide could have accomplished the same thing with a little bit of shortening of her heel, and that's perfectly reasonable because I can tell you I was on the struggle bus for this one. Yeah.
I bet.
So this is where we ended up, basically. So long story short, and this is a very long story, I was able to mobilize the tuberosity. There was a separate huge joint fragment that was just sitting behind her fibula that was completely independent. There was a lot of the subtalar joint. So I opted for fusion in this situation. And as you would expect, her peroneal tendons were sitting completely dislocated and had been for some time. She had a pretty significant equinus contracture because her heel had been so short and laterally basically dislocated. So I usually will do a Strayer or gastroc recession for these, and this way she actually got a Hoke triple lengthening, which I don't love doing in a young patient. And there's her fusion. I apologize for the poor axial image in the fluoro shots.
Wow. So what sort of adjunctive things do you have to do to get that length? You mentioned the Hoke, but did you have to put on, say, a distractor or anything else to try and get that length?
I basically did everything that I could possibly think of to do. So I had So I osteotomized it. I aggressively mobilized medially as safely as I could through that primary fracture line to free up that soft tissue off the medial wall of the calcaneus, which, I mean, you could make an argument even for doing a separate medial approach in this situation to do it. I didn't want to do that. And then I used a distractor. I actually had a distractor from her fibula, so I had a hinterman from the fibula into the calcaneus. I used shan spins into the calcaneus, trying to mobilize that tuberosity like you would for a primary fracture. I used a distractor against that piece, or excuse me, not distractor, a lamina spreader between the tip of the fibula and that lateral wall to try to push that thing down, because getting that length, getting the length of it was the hardest thing for me. And I think if you obviously look critically at these images here, you know, I mean, I think we've got the tuberosity back underneath her limb. She still has shortening, right? You can look at that primary fracture line, and you can see that I did not restore her all the way over immediately, and I couldn't do it. I couldn't get her there. Now she's still got some residual varus of the tuber as well, even though it's aligned, and that's the challenge with this.
I'll tell you what, it looks a lot better than it did beforehand.
Thanks. I felt okay about it. So anyway, this is actually, there was a further episode of this. I don't know if you looked. These are actually different screws. So she actually came back at a year and was having a lot of anterior ankle pain, injections, braces, orthotics, didn't fix it. She actually got the world's wimpiest bone block. You can see it hiding in there to restore a little height. So she actually had a healed fusion. I redid it because I'm a crazy person, and did a bone block on her. She is, as far as I can tell, happy. She is back working as a bartender. Certainly shoe wear is still a challenge for her. She can't wear all the shoes she wants, but she is walking and doing okay. But this story is not done, as you guys know. You know, so here's her subtalar fusion. This is, again, I'm a huge fan of these weight-bearing CT scans. I think we underestimate healing in a lot of these cases, and that can be cause of symptoms. But here she is, and obviously the alignment is much better, but still not perfect.
Right. Yeah, I didn't see anything additionally done in the forefoot and the midfoot. I'm assuming that when you brought that tuberosity back over underneath the talus, that didn't induce any obligate forefoot issues at all in terms of pro or supination.
No, not in this situation. I mean, I think she is young, healthy, fairly mobile, right? So I think this was 8 months, not, you know, a couple of years. So no, I don't think she, at least as far as I can tell, didn't have any secondary issues.
Sure.
That looks great.
Well, if the audience doesn't have any questions, we may be at the point here where we're getting towards the end of our hour and have to talk about wrap things up a little bit. Just real briefly, Brian and Dion, do you have any couple take-home points from each of your guys' talks on principles and talus to leave the audience with?
Yeah, I think one of my take-home messages would be to talk to a lot of people when you're doing these cases to see, you know, not as first talk to the patient, see what their expectations are, but then, you know, talk to your mentors, your partners, to see, you know, there's going to be different options. There's not one way or in one correct way to do these things and to reconstruct these complicated issues, because you got to be thinking about, hey, if I do this, what can happen down the road? And it's always good to have some experienced minds and brains helping you out on your way.
And Brian, anything vis-a-vis the learning principle of understanding the necessary steps for pre-op evaluation?
Yeah, I mean, I think the take-home point for me is just the essential nature of pre-op planning in these. And I know that's been harped on again and again, but for these things, I mean, it's much better to sit down with these images. And again, this isn't a hot trauma that came in. You can sit down, take your time, and figure out what steps you need to do and accomplish to get this done. And it's much better to figure out that step 3 just isn't going to work and it's time to start over and make a new plan than be in the middle of this operation and figure out that you can't get done what you set out to get done.
Right. So on behalf of the OTA and AOFAS, I want to thank my co-presenters, Jan Sekowski of Indiana University and Brian Weatherford of Illinois Bone and Joint, as well as our OTA staff that's online as well with us too, specifically Osman, who's helping with technical stuff, and Sarah Arns of OTA. Thanks very much, and thanks to all of you audience members for your participation and taking some time out of your busy schedules to be with us. With that, this is Pat Yoon from the Minneapolis VA, Thanks for joining us tonight, and hope everyone has a good night.